Welcome back to the deep dive. Today, we are shifting gears significantly. Usually we take a broad look at interesting topics, but today we are going into full, exam mode. We have a stack of heavy hitters on the table, Miller, Morgan, and Mikhail, the standard ICU protocols, and we are targeting a very specific listener. If you are an MD anesthesiology candidate, specifically if you are prepping for the Gujarat University curriculum or similar high-stakes board exams, this is your dedicated study session.
That's right. And honestly, even if you aren't sitting for an exam tomorrow, this is the one topic you cannot afford to be rusty on. We are talking about malignant hyperthermia, or MH.
Right.
It is essentially the anesthesiologist's boogeyman. It's the nightmare scenario we train for but hope we never ever see.
It really is. It's that rare catastrophic event that looms in the background of every single induction. But for the purpose of the exam, it is absolute gold.
Oh, absolutely.
It shows up everywhere. Long answers, short notes, and it is a favorite for the Viva Voce. So the mission for today is simple. We are going to act as your senior faculty mentors. We are going to break this down exactly how you need to present it to an examiner to get those full 20 marks.
Precisely. And I want to be clear right from the start. This isn't just about memorizing a drug dose. You need to understand the mechanism. If you understand the molecular defect, the clinical picture makes perfect sense.
Okay.
And if you understand the clinical picture, the management protocol becomes intuitive. So we're going to move from the gene to the cell to the patient and then to crisis management.
Let's set the stage then with Section 1, Introduction and Exam Framing. In an exam, specifically a long answer question, you often get a prompt like, describe the etiology, pathophysiology, and management of malignant hyperthermia.
Classic.
Right. And I think the biggest mistake candidates make is jumping straight to, it's a reaction to halothane. You need to be more professional. You need a definition that lands with authority. How do we frame this?
You need to hit 4 keywords. Malignant hyperthermia is a pharmacogenetic, life-threatening hypermetabolic disorder of skeletal muscle. Let's unpack that because each of those words carries marks.
Okay, let's do it.
We're first, pharmacogenetic. It's an inherited susceptibility that's triggered by specific drugs. It's not an allergy, it's in your genes.
Got it. Genetic.
Second, life-threatening. That's self-explanatory, but it's important to state it up front to show you grasp the severity.
Sure.
Third, hypermetabolic. The body's engine is running completely out of control. This single word explains almost all the symptoms we're about to discuss.
Okay, and the fourth?
Skeletal muscle. This is the site of the pathology. It is a primary myopathy. It's not a brain issue. It's not a blood issue. It's a muscle issue.
And that distinction about skeletal muscle is crucial because it helps you differentiate it from other hyperthermic states later on, right? Like neuroleptic malignant syndrome, which is central.
Exactly. That's an advanced point, but you're spot on.
Yeah.
Now, why do examiners obsess over this? It's because of the history and, frankly, the stakes involved.
What was the history?
If you look back to when MH was first described, the mortality rate was around 80%.
80?
80. Just let that sink in. 4 out of 5 patients who developed MH in the operating theater died. It was basically a death sentence.
That's horrifying.
It is. Today, with early recognition and, crucially, the introduction of Dantrolene, mortality is less than 5 to 10%. That incredible drop in mortality is almost entirely dependent on one thing: vigilance.
The anesthesiologist's vigilance.
Yes. If you recognize it early, the patient lives. If you hesitate, if you dither, the patient can die. That is why examiners will fail you instantly if you miss the basics of this topic. You are the only person in that room who can diagnose it in time.
That's a sobering thought. Okay, let's get into the weeds. Section 2 of our outline is etiology and genetic basis. This is marked as very high yield. If you're writing a long answer, you need a distinct section on genetics.
Absolutely. You must state this clearly. MH is inherited in an autosomal dominant pattern.
Autosomal dominant. So if one parent has the gene, there's a 50% chance their child inherits it. It doesn't skip generations in terms of the gene itself, though the expression might vary.
Exactly. And that brings us to the concept of variable penetrance. This is a classic Viva trap.
What does that mean in practical terms?
Variable penetrance means that even if you have the gene, you don't necessarily express the full-blown syndrome every single time you're exposed to a trigger. In fact, and you should write this down, roughly 50% of patients with MH have had a previous uneventful anesthetic.
Wow, that is a terrifying statistic. So the patient history might say, oh, I had my appendix out 3 years ago with general anesthesia and I was fine.
Right.
And you might think,
great, they aren't susceptible.
And that assumption could kill them.
It could. Just because they survived exposure to sevoflurane 5 years ago doesn't mean they won't react today. The threshold for triggering might depend on other factors: stress, body temperature, the duration of the surgery, maybe even the specific combination of drugs.
So a positive family history is a huge red flag, but a negative personal history does not rule out MH.
You've got it. That's a key safety principle.
Okay, so where is the defect specifically? We need to be precise for the exam.
The primary defect is on chromosome 19. The gene you need to name is RYR1. This gene encodes the ryanodine receptor type 1.
RYR1.
There are other rarer mutations, like in the CACNA1S gene, which affects a different part of the calcium channel. But for your exam, RYR1 is the money answer. 95% of the time, it's RYR1.
The ryanodine receptor. We hear this term constantly in physiology.
Yeah.
Can you give us a conceptual way to visualize what this receptor actually does? Something we can picture in our heads during the exam.
Of course. Think of the muscle cell. You have the T-tubule, which is like an electrical wire that brings the signal in from the cell surface. And deep inside the cell, you have the sarcoplasmic reticulum, the SR.
Right, the calcium storage tank.
Exactly. The SR is a big bag full of calcium. The ryanodine receptor is the physical connection, the foot process, that links the electrical wire, the T-tubule, to the gate on the storage tank, the SR.
So it's the gatekeeper, the plug in the drain.
Precisely. In a normal person, the electrical signal comes down the wire, the ryanodine foot lifts, the gate opens, calcium rushes out, and the muscle contracts. Then the signal stops, the gate closes, calcium gets pumped back into the tank, and the muscle relaxes. Simple.
But not in MH.
In MH, that RYR1 receptor is mutated. It's defective. When it comes into contact with a trigger, like halothane or sevoflurane, that gate gets stuck open. It becomes a leaky channel.
Or more than leaky.
Well, leaky is probably too mild a word. It's a wide-open floodgate. Calcium just pours out of the sarcoplasmic reticulum into the cell cytoplasm, and it simply will not stop.
So the cell is just flooded with calcium, and we know calcium is the key that turns on the engine of muscle contraction.
Correct. And before we leave genetics, we must mention the associated conditions. This is an exam favorite because it tests deeper knowledge.
What are they?
Because it's a genetic defect in the muscle structure, it overlaps with other myopathies. The strongest association you absolutely must know is central core disease.
Central core disease. So if a patient has that diagnosis in their chart, what does that mean for me?
You treat them as MH susceptible. Period. No debates, no questions. They get a trigger-free anesthetic. The same goes for King-Genborough syndrome.
What does that look like?
It often presents with some dysmorphic features. Things like short stature, a webbed neck, low-set ears. If you see a kid with those features coming for surgery, your MH antenna should go way up. You should also mention multi-minicore disease.
And I noticed the source should make a specific point about Duchenne and Becker muscular dystrophy. Is that MH? This seems to be a major point of confusion for students.
Right. This is a nuance you must get right to distinguish yourself as a top candidate. Patients with Duchenne or Becker MD are at extremely high risk for a catastrophic reaction to succinylcholine. They can get massive rhabdomyolysis and fatal hyperkalemia. It looks like MH, and it can certainly be fatal, but the underlying mechanism is different. It's a defect in the dystrophin protein in the cell membrane, not a ryanodine receptor defect.
I see.
However, clinically, we exercise the same extreme caution. We avoid succinylcholine in these patients at all costs. But for the purist examiner in Viva, Duchenne is not classic MH. It's a different pathophysiology leading to a similar crisis.
Got it. Okay, that's clear. Let's move to section 3, triggering agents. This is an exam favorite, a list you just have to know. It seems simple, but we need to be precise. What is on the unsafe list?
The unsafe list is short, but it's deadly. It includes all the potent volatile anesthetic agents.
All of them.
All of them. Halothane is the classic, most potent trigger, but don't you dare forget the modern ones. Isoflurane, sevoflurane, zeflurane, and fluorane, they're all triggers. A simple rule: if it goes in a vaporizer, it's a trigger.
Okay, that's easy to remember. And the muscle relaxant.
Succinylcholine. It is the only depolarizing muscle relaxant we use and is a potent trigger. It can trigger an MH crisis all by itself, but it really acts like an accelerant if you use it with a volatile agent. It makes the onset of the crisis faster and much more severe.
So that's the do not touch list.
Yeah.
But equally important for the exam and for actually saving the patient is the safe list. What can we use?
We have plenty of good options. This is important because you still have to anesthetize the patient for their surgery.
Right.
First, nitrous oxide. This is a common exam question. Is N2O a trigger? The answer is no, it is not. It is safe.
Okay.
Second, all of our 5E induction agents. Propofol, biopentone, ketamine, etomidate, all of them are safe.
Good.
Third, opioids, Fentanyl, morphine, remifentanil, sufentanil, all completely safe. Fourth, the non-depolarizing muscle relaxants, rocuronium, vicuronium, etricurium, cisatricurium, all safe.
And local anesthetics.
And finally, yes, all local anesthetics.
Ugh.
Lidocaine, bupivacaine, ropivacaine, both the amides and the esters are safe.
So if you have a known MH-susceptible patient, you're looking at doing a TIVA total intravenous anesthesia or a regional block.
Exactly. A spinal or an epidural is a fantastic choice for these patients if the surgery allows for it. If you absolutely must do a general anesthetic, you do what's called a trigger-free GA, using things like propofol and remifentanil for maintenance and rocuronium or vicuronium for muscle relaxation.
Let's unpack the mechanism further. Section 4, Pathophysiology. This is the core of the exam answer. We established that the calcium gate is stuck open. What happens next?
This is what I like to call the calcium cascade. It's a vicious cycle. The sarcoplasmic reticulum dumps massive amounts of calcium into the myoplasm, the cell's cytoplasm.
Right.
This high intracellular calcium binds to troponin, which then moves tropomyosin out of the way. This uncovers the binding sites on actin, allowing actin and myosin to interact.
Which is muscle contraction.
But it's a sustained tetanic muscle contraction. The muscle is locked in the on position. It can't relax.
And muscle contraction requires energy, a lot of it.
Massive amounts of energy. The cell tries frantically to fix the problem. It tries to pump all that excess calcium back into the storage tank using its circupumps. That process burns ATP. The contraction itself is burning ATP. The cell burns through its entire energy stores in minutes. This leads to profound ATP depletion.
And when you burn that much ATP, you produce a lot of waste products.
Correct. The metabolism shifts into an uncontrollable overdrive. First, oxygen consumption, the VO2, skyrockets. The muscle is essentially running a marathon while standing still. It's gasping for oxygen.
Which means the blood coming back to the heart would be very desaturated.
Severely.
Yeah.
You'd see a big drop in your mixed venous saturation. Second, CO2 production explodes. This is crucial for the diagnosis. The aerobic metabolism is running at 1,000% capacity, just churning out CO2.
And with metabolism comes heat.
Yes. Third, heat generation. Heat is a fundamental byproduct of this metabolic inefficiency and all the ATP being hydrolyzed. And finally, when the oxygen supply just can't keep up with the insane demand, the cell switches to anaerobic metabolism.
Which produces lactate.
So
we have a hypermetabolic state leading to a profound acidosis.
a severe mixed acidosis.
Yeah.
You get a respiratory acidosis because of the massive CO2 production that the ventilator can't clear, and you get a metabolic acidosis because of the lactate.
And then the cell itself starts to fall apart.
Exactly. The cell membrane, the sarcolemma, loses its integrity. It starts to break down. This is rhabdomyolysis. The contents of the muscle cells spill out into the bloodstream.
What spills out? What are we most worried about?
First and foremost, potassium. That's the immediate killer. The sudden, massive hyperkalemia leads to arrhythmias and cardiac arrest.
Okay.
Then myoglobin spills out. This big protein clogs up the renal tubules and causes acute kidney injury. And finally, creatine kinase, CK, spills out, reaching absolutely astronomical levels. A normal CK might be under 200. In MH, it can be over 20,000.
This paints a very chaotic, very rapid picture, which brings us to Section 5, clinical features. The sources really emphasize identifying the early signs versus the late signs. This seems to be where students lose marks.
It is. I'll say this bluntly. If you write fever as the first clinical sign of malignant hyperthermia in your exam paper, you have failed the question. You've shown you don't understand the sequence.
Okay, let's shout that from the rooftops. Fever is a late sign. So what is the earliest and most sensitive sign we need to be looking for?
The single most sensitive and specific early sign is a rising end-tidal CO2, EtCO2.
Explain that.
Imagine you have a patient on a ventilator. The ventilation settings, the respiratory rate, the tidal volume, they haven't changed. But suddenly you look at your monitor and the EtCO2 starts climbing. It goes from 35 to 45, then to 55, then to 60 millimilli HD.
So your first instinct would be to increase the ventilation.
Right. You increase the minute ventilation to try and blow it off.
Yeah.
But it keeps rising. That is the hallmark of MH. The body is producing CO2 far faster than you can possibly breathe it out. It's an unexplained refractory hypercarbia.
Okay, so unexplained rising EtCO2 is number one. What else is early?
Tachycardia. An unexplained sinus tachycardia is often the very first sign, but it's very nonspecific. It could be light anesthesia, it could be pain, it could be hypovolemia.
Sure.
But if you have tachycardia plus a rising EtCO2, your alarm bells should be screaming. The third key early sign is masseter spasm or masseter muscle rigidity. MMR.
The jaws of steel.
Yes. This typically happens right after you give Succinylcholine. You go to open the mouth to intubate, but the jaw is clamped shut. It's rigid like a board. If you encounter this, you must assume it could be the start of an MH crisis. If the jaw is truly rigid and you can't open it, stop. Don't give more relaxant.
So the triad to watch for: rising EtCO2, tachycardia, and masseter spasm. Now, tell us about the late signs, the signs of systemic failure.
If you miss those early signs, the patient spirals downwards very quickly. Hyperthermia develops, and it's a rapid rise. 1 degree Celsius every 5 minutes is not uncommon. It can go up to 43 or 44 degrees.
Yeah.
But again, if you wait for the fever, you've waited too long. You will see cyanosis and mottling of the skin due to the massive oxygen consumption by the muscles. The venous blood is almost black. You will see dark urine, classically described as cola-colored, due to the myoglobinuria.
And the heart.
And finally, cardiac arrhythmias, particularly ventricular arrhythmias, because of the severe hyperkalemia. And eventually, cardiac arrest. Your lab findings will confirm all this. A severe mixed acidosis on the ABG, dangerously high potassium, hypermagnesemia, and that massive CK elevation we talked about.
It's a terrifying progression. Now, Section 6, differential diagnosis. In the OT, not every tachycardia is MH. How do we differentiate this in real time?
This is the thinking anesthetist part of the exam. You have to be logical. First, light anesthesia. This is the most common cause of tachycardia and hypertension.
So how do you tell the difference?
Light anesthesia won't cause a massive metabolic acidosis or a rapid EtCO2 rise that resists changes in ventilation. If you deepen the anesthetic and the signs resolve, it was likely light anesthesia. In MH, deepening with a volatile agent makes it worse.
Okay. What's next on the list?
Thyroid storm. This can present with tachycardia, hyperthermia, and arrhythmias. The key differentiators are a history of thyroid disease and the fact that CO2 production is usually not as massively elevated as in MH. Also, hypokalemia is common in thyroid storm, whereas hyperkalemia is the rule in MH.
What about neuroleptic malignant syndrome?
NMS. Similar features, yes, rigidity, fever. But it's caused by antipsychotics, dopamine blockers. The key difference is the onset. NMS is slow. It develops over days or even weeks. MH is acute, happening over minutes to hours in the OT.
Okay, a few others to consider.
Sure. Sepsis can cause fever and tachycardia, but it's usually a slower onset and is associated with hypotension early on. During laparoscopy, the insufflation of CO2 into the abdomen can raise your EtCO2, but that usually reaches a plateau and responds to ventilation changes, unlike the relentless rise in MH. And finally, a Pheochromocytoma crisis causes wild swings in blood pressure and heart rate, but typically not muscle rigidity.
Moving on to diagnosis in Section 7. In the acute crisis, the diagnosis is purely clinical. You don't wait for a lab test. The sources mention the LARAC clinical grading scale.
Right. That's a formal tool that assigns points for rigidity, muscle breakdown, respiratory acidosis, temperature, and cardiac involvement to help retrospectively classify an event. But in the moment, it's about pattern recognition.
And what about the gold standard test for after the event to confirm susceptibility?
The definitive test is the in vitro contracture test, or IVCT, sometimes called the Caffeine-Halothane contracture test, the CHCT.
And how does that work?
It's quite invasive. It requires a fresh surgical biopsy of muscle, usually from the vastus lateralis in the thigh. The muscle strips are put in a bath and exposed to controlled concentrations of halothane and caffeine. An MH-susceptible muscle will contract much more forcefully at lower concentrations than normal muscle.
Well, genetic testing, is that an option?
Yes, we can do genetic screening for known RYR1 mutations. It has a high specificity, meaning if the test is positive, they definitely have the susceptibility. But its sensitivity is lower because a negative test doesn't completely rule it out, as we haven't identified all the possible causative mutations yet.
Okay, now for the most critical part of this deep dive. Section 8, immediate management. This is marked very high yield, must be stepwise. I want you to walk us through this. You are in the OT. The EtCO2 is 65 and rising. The heart rate is 130. The patient feels warm. Go.
Okay, first things first. Part A, immediate actions. You have to do 4 things simultaneously. 1, stop the trigger. Immediately turn off the vaporizer. If acetylcholine is infusing, stop it. This is number 1.
Okay, on the trigger.
2, hyperventilate. Increase the minute ventilation 2 to 3 times the normal. And use 100% oxygen at high flows, 10 to 15 liters per minute. You need to wash out the volatile agent and try to blow off that CO2.
Got it.
3, call for help. This is not a solo mission. You declare the emergency out loud. I think this is malignant hyperthermia. I need help, and I need the MH cart now.
The MH cart.
Every hospital has one. It's a dedicated trolley with all the drugs and equipment you'll need. 4, if you can, change the circuit. Some protocols advise changing the breathing circuit and the soda line canister to remove any residual anesthetic gas. Or if you have them, you can insert activated charcoal filters into the circuit, which are very effective at scrubbing the gas.
Okay, triggers off, oxygen on, help called. Now, the magic bullet, step B.
The Dantrolene. This is absolutely essential and non-negotiable. The mechanism. Dantrolene is a direct-acting muscle relaxant that works as a ryanodine receptor antagonist. It blocks that leaky calcium channel at its source.
It plugs the floodgate.
It plugs the floodgate. It uncouples excitation contraction. The dosing. 2.5 milligrams per kilogram, IV bolus immediately. Don't hesitate.
And you repeat it?
Yes. You repeat the 2.5 millikilogram bolus every 5 to 10 minutes until the symptoms start to subside. You're looking for the ETCO2 to come down, the rigidity to relax, the heart rate to slow. The max dose is usually cited as 10 millikilogram, but you give what's needed.
A quick word on preparation. It's famously difficult to mix, isn't it?
The older formulation, Dantrium, is each 20 milligram vial needs to be reconstituted with 60 milligrams of sterile water. So for an 80 kilogram patient, that's a 200 milligram dose, which is 10 vials. That's 600 milligram a liter of sterile water you need to draw up and inject.
That takes time.
A lot of time.
Yeah.
You need dedicated people from your help team whose only job is mixing Dantrolene. The newer formulation, Ryanodex, is a godsend. A single 250 milligram vial mixes in just 5 milligram water. Much, much faster.
Okay, Dantrolene is in. Now we move to supportive management, part C.
Right. C, supportive management. Now you're treating the consequences. 1, cooling. You need to actively cool the patient. Surface cooling with ice packs to the axilla, groin, and neck. Give cold IV saline, chilled to 4 degrees Celsius. If the abdomen or bladder is open, you can do cold lavage.
When do you stop cooling?
You stop actively cooling when the core temperature reaches 38 degrees Celsius. You have to be careful not to overshoot and cause hypothermia.
Okay. What about the acidosis?
Treat the acidosis. Give sodium bicarbonate 1 to 2 milliequivalents per kg, guided by your arterial blood gas results.
And the hyperkalemia.
Treat the hyperkalemia aggressively. This is what will cause cardiac arrest. Give insulin 10 units with dextrose 50%. Give calcium gluconate to stabilize the cardiac membrane.
Is it safe to give calcium, given that the problem is excess calcium?
Yes, that's a common point of confusion. It is safe. The calcium gluconate doesn't enter the muscle cell. It works on the outside of the cardiac cell membrane to restore the electrical gradient and protect against arrhythmias. It is not contraindicated.
What is contraindicated for arrhythmias?
This is a critical point. You must avoid calcium channel blockers like verapamil or diltiazem. In the presence of dantrolene, they can cause life-threatening hyperkalemia and complete cardiovascular collapse.
Okay. And finally, the kidneys.
Protect the kidneys. Diuresis. You need to maintain a high urine output, more than 2 milliliters per kilogram per hour, to flush out the myoglobin and prevent renal failure. Give plenty of IV fluids, and consider using mannitol or furosemide.
Section 9 lists the awful complications if this isn't managed well. Renal failure from the myoglobin, DIC from shock, cardiac arrest from hyperkalemia, compartment syndrome from the severe muscle swelling, and cerebral edema. Assuming we save the patient, what about Section 10, post-crisis management?
The crisis isn't over when the patient leaves the OT. ICU transfer is mandatory, no exceptions. They need intensive monitoring.
Why?
Because you have to watch for recrudescence. In about 25% of patients, the symptoms can recur within hours, as the initial dose of dantrolene wears off.
So you continue the treatment?
Yes. You must start a dantrolene maintenance infusion or intermittent bolus, usually 1 milligram per kilogram every 4 to 6 hours, continued for at least 24 to 48 hours.
What are you monitoring in the ICU?
You're monitoring everything: serial creatine kinase levels, electrolytes, coagulation profiles, and urine output, watching for that myoglobin. And then, long-term, counseling. The patient needs to be registered with an organization like the Malignant Hyperthermia Association of the United States, or MHA-US. They need a medical bracelet, and their family members must be told they need to be tested.
Right, because it's genetic. Okay, Section 11, prevention and anesthetic implications. This is key for any patient with a known or suspected susceptibility.
It is. It starts with the pre-op evaluation. You must ask about a personal or family history of death under anesthesia or an unexplained high fever during surgery.
And if you identify a susceptible patient, how do you manage them?
First, schedule them as the first case of the day. You want the cleanest possible anesthesia machine.
What does machine prep involve?
You need to remove the vaporizers from the machine. Then you flush the machine with high-flow oxygen, 10 liters per minute for at least 20 minutes. though the exact time varies by machine manufacturer. You must change the CO2 absorbent and the entire breathing circuit.
What about the technique?
You use a safe technique. Viva with propofol and remifentanil is a great option. Or even better, regional anesthesia. A spinal or epidural is perfectly safe. And for monitoring, in addition to all standard ASA monitors, a core temperature probe is mandatory from the very beginning.
Fantastic. Now let's do a quick role play for Section 12. Common exam questions and Viva traps. I'll be the examiner. First question. Is temperature the first sign of malignant hyperthermia?
No, absolutely not. It is a late and inconsistent sign. The earliest, most reliable sign is an unexpected rise in end-tidal CO2. You should not wait for a fever to diagnose or treat MH.
Good. A patient is having ventricular arrhythmias during an MH crisis. Can I use calcium channel blockers to treat them?
No, calcium channel blockers are contraindicated for use with Dantrolene. Their combination can precipitate life-threatening hyperkalemia and cardiovascular collapse. You should use agents like amiodarone or lidecamide.
Okay. Is Masseter spasm always malignant hyperthermia?
No, not always, but it is a major warning sign and a harbinger of MH. If the jaw is tight but can be opened slightly, it might be an exaggerated response. But if it's rigid jaws of steel, you should assume it is MH until proven otherwise. The safest course is to stop all triggering agents, and if the surgery is emergent, switch to a Viva technique.
Does a previous safe anesthetic rule out MH?
No. Due to variable penetrance, approximately 50% of MH-susceptible patients have had a prior uneventful anesthetic. A negative history does not guarantee safety.
Perfect. Section 13. Diagrams and exam presentation. How should a student structure their 20-mark answer?
You need clear headings. Start with an introduction, your 4-keyword definition plus the genetics, then a section on triggers, listing the safe and unsafe agents. Then pathophysiology, explain the calcium cascade. After that, clinical features. You must separate early versus late signs.
And then the biggest section.
Management. Break it down into immediate actions, Dantrolene, and supportive management. Be stepwise. Finally, add a small section on prevention for the susceptible patient. And if you can, draw a simple flowchart for the management protocol. It shows clarity of thought.
Let's do a final summary for Section 14 then, the high-yield recap.
Okay, 1. MH is a genetic autosomal dominant defect in the RIR1 receptor on chromosome 19. 2. It's triggered by all volatile anesthetics and succinylcholine. 3. The core problem is uncontrolled calcium release from the SR.
4.
This causes a hypermetabolic state. 5. The hallmark early signs are rising EtCO2 and tachycardia. 6. Fever is a light sign.
7.
The definitive treatment is Dantrolene, 2.5 mg/kg IV. 8. You must stop the trigger and call for help immediately. 9. Manage hyperkalemia and acidosis aggressively. 10. Avoid calcium channel blockers. 11. All patients require ICU admission post-crisis. 12. A negative personal history does not rule it out.
That's a great list. And your final exam tip?
In a Viva, if the examiner gives you any scenario with a patient whose EtCO2 is rising unexpectedly, even if they don't mention MH, one of the first things out of your mouth should be, I would immediately consider and start to exclude malignant hyperthermia as a cause. It shows you're thinking about the worst-case scenario.
And what's our provocative thought to leave our listeners with?
The interesting and growing link between MH and exertional heat stroke. Some individuals who suffer from severe non-environmental heat stroke during intense exercise have been found to have the same RYR1 mutations as MH patients. It raises the question, are they in some cases two sides of the same coin? A defect in calcium handling that can be triggered by drugs in the OT or by intense physiological stress out in the world?
That's a fascinating area of research. That brings us to the end of this deep dive. Our advice to you is to visualize this MH crisis protocol. Run it in your head so you can recite it automatically in the exam, and more importantly, perform it instinctively in the OT.
And go to your operating theater and find the MH card, open it. Look at the Dantrolene. Read the mixing instructions for the specific formulation your hospital stocks. Practice it in your mind. Be prepared. Good luck.
See you next time.